Yeah.
Yep, that's recording. Cool. Yep.
Cool, just getting people coming in.
That looks like a substantial library behind you, Annie.
Yeah, it's a good backdrop.
Is it real or is it?
No, it's real. Yeah.
I should get the Library of Congress behind me to try and compete.
I haven't read like 95% of these though, so I better start with.
At least you've got your hands on them, so
That's right.
That's what counts with books, I think. If they sit on your shelf, they by osmosis get into your mind.
Okay. Should we make a start or wait for a few more minutes?
Maybe give them 5 minutes.
Yeah. Okay, we'll start 5 past maybe.
Sometimes people have trouble getting the link going, so. So when are you back in classes? Do you know, Annie?
Well, we're doing online learning for the rest of semester 1.
Right.
I don't think they've made a decision as to what semester 2 is going to look like, but
well, I think they're being very cautious. They're I think slightly terrified for the University of Auckland to become a cluster, so they would rather err on the conservative side. It wouldn't look good overseas, I don't think, if we had a university cluster. So
yeah, fair enough.
They're being very cautious.
Yeah, okay. I'll just ask everyone that's coming in to make sure that their microphone's muted. And if you want to, you can have your video up, but just be aware that we will be recording this and it will be uploaded onto YouTube, I think, or Facebook. Yeah.
So Annie, would you want me to talk about COVID first and then some cases, or what are you going to interview me, or how are we going to do this?
Yeah, so I'll basically give a quick introduction to tonight's event. And while the plan is that for the first half, we'll have you talk about COVID and how that sort of affected general practice. And then the second part would be your cases, if that's what you like to do. Yep. And then the third part, we just have like a short sort of Q&A session for anyone who wants to ask questions. So yeah, we'll see whether people have those for you.
And Teresa should be here by 1:15, so that will be that'll be good.
Yeah. Okay, I'll just check the time.
Okay. When should I show my T-shirt? I've got it here.
Whenever you like. Yeah, I'll be pretty fast. My introduction, just something quick, and I'll pass on to you.
Yeah.
Okay, I think we'll make a start. Nice, we've got quite a few people in today. Okay, yeah. So for those that's just come in, just make sure you've got your microphones muted, or just make sure you're not making too much sound. And if you like, you can have your video up, but just be aware that we're gonna record this and upload this somewhere. Great, okay. So can I just get like a thumbs up or something just to make sure my audio is okay? Can you guys all hear me? Thank you, Bruce. Cool, okay. So welcome everyone to the first online event organized by the GP Interest Group. My name's Annie, and I'm the 2020 Auckland Events Officer for the GP Interest Group this year, and I'll be your MC for tonight. So this evening, we are joined by Professor Bruce Arrow, who's a practicing GP at Greenstone Family Clinic in South Auckland. And then later on, we'll be joined by Dr. Teresa Mittermeier, who's a second-year GP registrar based in Silverdale. And we're meant to have Chelsea tonight, but unfortunately, she can't make it due to an unforeseen circumstance. Okay, so tonight, Bruce and Teresa will be speaking about what general practices look like during the COVID-19 pandemic. And I'll give a really quick rundown of what's going to happen, and then I'll pass on to Bruce to let him introduce himself a little bit more. So during the first half, Our speakers will talk about the changes that they have experienced in general practice during the pandemic. And then the second part will involve the presentation of cases in general practice. And I'm not sure if that's still going to happen, but also cases in trauma care. And lastly, we're going to do a little Q&A session for you guys to ask any questions you might have. And feel free to send the questions through on the chat as we go. You don't have to wait till the end. And if you feel like you don't want to reveal your name, just sort of private chat me the questions, and then I will ask Bruce those for you. Great, and that's it from me. Do we have any questions about any of that? Think we're okay? Good. Okay, so I'll pass on to Bruce now.
Okay, well, kia ora tātou everybody, and thank you for the invitation. And one of the things I like to say to our clinical students is, in some ways, this is a great privilege for you to be able to witness a pandemic, because I've been in practice 40 years now, and this is really the first pandemic. SARS and swine flu and MERS really didn't have much impact in New Zealand. So this is the first one. And what's been really exciting is seeing how two of our graduates, and one is Ashley Bloomfield, who's a graduate of the University of Auckland, and Michael Baker, both graduates from the University of Auckland, have been the leading advisors to the government. And you can see how public health's an interesting specialty. There's an old joke about public health. Good public health is when nothing's happening, and that means everything's under control. But of course, you get these emergencies in public health, and we had measles not so far ago, and then we've had COVID. We had the Campylobacter situation in Havelock North, where 5,000 people got Campylobacter, which is a very unpleasant diarrheal illness from drinking the city water. So that was pretty terrible. So I guess in the early days of COVID, I wasn't sure how serious it was, but it was quite clear to people like Michael Baker and Ashley Bloomfield that things were not good overseas. And since we've been in lockdown, I've been able to look at the figures from Italy. And in some ways, we were pretty lucky, because if you think of all the visitors we have from China, we could have quite easily have been one of the earlier exposures to the virus. But it looks like Italy got the first lot. And it was extraordinary looking at the mortality of people there. If you're over 80, it's 20% of people who got COVID died from it. If you're in your 70s, it was like about 10%. And if you're in your 60s, it's about 3 to 5%. Those figures have come down for the United States, but it's very hard to know what the denominator is for these things. But with our clinic, we, once we realized that we were going to have to start swabbing people, we didn't have any, it wasn't easy to get the PPE, and our nurses sort of cobbled together these little packs. So we had 4 COVID sets of PPE with goggles, hat, mask, gown, and prepared for our first patient coming in. And it was slightly scary having somebody coming in who'd traveled overseas, so they were potentially at high risk, or they'd been in contact with somebody with COVID. And the whole place was very, very stressed. And the whole first swab took about an hour to do, because you had to do this, you had to gown up, you had to do the swab, you had to do a whole lot of written stuff, and then take off the PPE and then talk to the patient. So the very first one took about an hour, and we started to think, we're not going to be able to cope with this. If we have what happened in Italy, then that's going to be that's going to be pretty hard to manage here, unless we actually allocated somebody just to do that all day. which of course in the financial situation of a primary care clinic is very, very expensive. You're paying a full salary to somebody just to do one thing, and they may not be that busy during the day. So I think one of the really smart things the government did was to get the CBACs, that's the community-based assessment clinics. So what that did was take all the acute respiratory infections, most of which weren't COVID, of course, but some of which were. And of course, you can't really tell the difference. The symptoms, there's enormous overlap with just the normal illnesses that occur in the community. So that took, and in a sense, it made regular primary care very much low risk. So in fact, it became quite safe, although we didn't make a lot of that. We actually kept all the elderly patients away from the clinic because of the mortality, basically. If we were going to have a mortality like Italy, 20% of people over 80, and a lot of people who come to general practice are older patients. They start getting chronic illnesses, they're getting onto more medication, and you know, a lot of the patients in primary care are older patients. So that was quite an issue. So the older people stayed away, and in a sense, we did mainly phone consultations and repeat prescriptions. So we're doing a lot of repeat prescriptions by phone, and then talking to a lot of people by phone, and in some cases by video. And this has been quite interesting, actually, because you realize a lot of the stuff you can do by telephone, you don't actually need to do video. And of course, once you invoke video, then you've got issues with the patient's camera facilities, their digital skills. I mean, you as doctors in training will have excellent digital IT skills, and presumably in most cases have some pretty good equipment. That doesn't necessarily apply out in the community. So, so trying to do things by phone is quite important rather than video. I did one video consultation. It was with a guy who was quite IT savvy. The rest of the consultations I've done by phone. If you want to look at something like a skin rash, then you need video, or the patients can take a photograph and email it or text it in so you can see. So a group of us wrote a paper called New Zealand Primary Care's Response to COVID-19, the response to the burning platform. And one of the things you'll discover in healthcare is things can take a very, very long time to change. But if there's a burning platform, and COVID was definitely a burning platform, things will change very quickly. So things change very quickly. We were told to do 90% of our consultations by remote means, basically telephone, or people, and with modern GP computers, people can request prescriptions online, and we can fill the prescriptions online and then get the prescriptions off to pharmacies. So that's been one of the things that's changed dramatically. There's been a special software developed this called DoxyMe, and I'll tell you a funny story about this that happened to me. The only time I used it, actually. But you could use Skype or you could use Zoom, depending on what. But DoxyMe is very easy for patients to use, and it's encrypted, so it's got a lot of advantages. There are software attached to the computer systems we use, but it's not necessarily as good. So DoxyMe turned out to be a very, very good device. And the other thing was rather sweet. Because of my age, my colleagues, my partners in the practice, decided to take me away from the front line and have me doing remote consultations. So for the last 6 weeks, I've been doing remote consultations. They were scared that if I got COVID, then my mortality might be significant. So that was very sweet of them. I thought that was quite a lovely gesture. Most of them are under the age of 40, and I'm over the age of 60. So I was in the at-risk sort of situation. So that was an enormous change in primary care. The waiting room is completely empty. It was flu vaccination season, and our nurses were magnificent. They ran a Saturday clinic where they did 100 flu vaccinations in the car park. People would drive in, roll their shirt up, and they'd get the injection, and unless they'd had a problem with previous flu shots, they could drive home. And the Immunisation Advisory Centre, so traditionally you had to have an injection and wait 20 minutes, but they realised it's very unusual for people if they've not had problems with injections before. So a little bit of risk there, but it meant that people in their cars, they weren't having to come into the clinic, because that was one of the things, one of the learnings from Italy was that people were catching COVID virus in doctors' waiting rooms. And isn't that terrible? You go to your doctor, perhaps for your blood pressure or your cholesterol management or your asthma management, and you catch COVID and you die. I mean, it's a pretty, that's sort of not what we're doing medicine for. And I think we've got 2 waiting rooms in our clinic. And I think when we go back to regular practice, we may put people with acute illnesses in one and people who are coming in for regular things, which would mean probably keeping the older people separated from young families, because it's young children who come in with most of the respiratory infections. Although, as you may have gathered, what's happened in the healthcare sector, because we've all been in quarantine, the regular colds and flus, which predominate at this time of year and create quite a bit of work for primary care and secondary care, Starship acute wards are virtually empty, as is the adult wards, because there's about 500 deaths a year from regular influenza. So we're able to keep, and I think when we go back, what we may do is actually keep people in separate waiting rooms, or call people in from the car park if they've got an acute illness and they come straight in to an acute clinic. We run an acute clinic at our clinic where you can come in for a single problem. So if you've got yourself a respiratory illness or a skin infection or an ear infection, you can come in and get that seen, but you just get that dealt with. If you want to come for something more complicated or a repeat of medication, then you need to come to a regular clinic, which you could book for. So most clinics run an acute clinic like that. So all the acute COVID cases were then going to the CBACs, and we were doing triage. So the front desk was asking everybody the 3 or 4 questions, depending what they were. Have you overseas travel? Have you been in touch with COVID? Are you a healthcare professional? And if you were yes to any of those, then more questions would be asked. We had to learn how to assess respiratory distress on the telephone. There are some tests which have been used with people with chronic breathing problems, where you ask them to count to 10 and see how quickly they can do that. And of course, if they're very breathless, they will have trouble counting to 10. It came down to, there's a very good article in the British Medical Journal. I don't know how many of you get my Goodfellow gems, but I'd suggest signing up to them. They're 2 weekly practice-changing facts. So go to goodfellowunit.org and have a look at the gem on assessing acute respiratory illness. And essentially what you decide there is somebody getting worse over a period of days? That, of course, is always a bad sign in clinical medicine if somebody's actually getting worse rather than getting better. The natural history for most illness should be it peaks and then people get better. If they're getting pain, it should be getting better. And it's one of the things you'll learn as doctors in training, that that's the natural pattern of people getting better. And if people aren't getting better, then you have to reassess them and perhaps consider sending them to hospital. So that's one of the skills you will pick up. So there were some, so I've been sitting at home doing counselling, talking to patients, and if they need to be seen at the clinic, one lady had injured her arm very badly, so that you can't deal with by telephone. So I got her to come to the clinic, and she needed to, yeah, Kelly's just put the Goodfellow gem there. Very, very slick there, Kelly, well done. So that's the assessment of breathlessness. Very good British Medical Journal article. So the gems come from the, so I'm looking at about 15 knowledge refineries. One of the things you're going to have to learn to access are knowledge refineries. There's too much information out there for you to keep up. So you need, so I'm looking at 15 knowledge refineries, and I picked the best and most important ones out of that. So if you can find somebody who's doing that anywhere in the world, and there's people doing this for all sorts of different disciplines, that way you can keep up with what's going on in your discipline. So the Goodfellow Gems, they're free to sign up to, and everything on Goodfellow Unit. In fact, the 4th and 5th year students and 6th year students who have been working from home mainly had found that the stuff on the Goodfellow Unit has been pretty good. Basically, it's been very, very useful for them. So I thought I might just tell you about some cases I've got. Oh, I thought just before I went any further that I would show you my Ashley Bloomfield t-shirt. So this is, you may have seen this. So that's a picture of our Director General of Health. And it's interesting, I supervised him for his public health training many years ago. And it was quite clear that he was going to do something big one day. I didn't know what that would be. I thought he'd become Director General of Health, but then they went for non-doctors for a while, and now they're back to having doctors again. And I think that's been a very significant key to handling this pandemic well, because he understands infectious disease, he understands how to talk to people about it. And of course, if you remember back, or you would have heard people refer to 1918, there were so many deaths in Auckland, they ran out of coffins. They had 2 trains a day taking deceased people to Waikomete Cemetery. And out of Waikomete Cemetery, there's a mass grave of people who died during the pandemic. It was much more devastating in the Maori community, about 7 times as many. The rate of death for Maori were about 7 times that of Pākehā. It was absolutely a devastating thing. There's a very good book called Black November, which talks about the 1918 epidemic. And the chap who wrote it had an interesting thing. When he was a young man in the 1960s, he used to ask his older relatives, the sort of thing I did when I was young. I talked to my older relatives who'd been in the First World War. And he said, what was the worst experience of your life? Fully expecting him to say, well, it was the trenches in the First World War. And to a person, they said, no, it was the 1918 influenza outbreak. Because people were literally, you'd wake up one morning and your next door neighbors would both be dead. This was happening all over the city. There was one story of some children running around in the front lawn of a house, and the neighbors went over to see what happened, and both the parents had died during the night. So people died very quickly. And back then it seemed to be younger people. There seemed to be a massive immune response. I remember meeting a man who said his brother got unwell in the morning, was dead by nighttime. People got a very, very vigorous response to the influenza virus. It seemed like older people were a little bit spared because there'd been an influenza epidemic about 20 years before, and they think the older people actually got some immunity to it. So that was interesting. But I thought I'd tell you about a couple of sort of experiences. One was quite funny. So with this DoxyMe software, you have to text a link to the patient. And I had this 24-year-old man who'd arranged to talk to me about his mental health. And when I typed it, instead of an F, the D is right. By the D, there's an F. So instead of doxing me, I'd written foxy me. And I thought, I looked at this and I was horrified. And unfortunately, I actually caught it before I went out. And I didn't think that the medical council would be very impressed with me sending out internet links with foxy me written on it rather than doxy me. So anyway, I managed to save the day. And that's pretty good software. It puts patients into a waiting room. So you get a message on your computer saying that the patient is in the waiting room, and then you usher them in, and then suddenly they're there on your screen. So that was quite interesting. The other thing that is quite interesting, I do a lot of mental health consultations, and I'm very used to patients crying in front of me. In fact, in my clinic, I'm very organized. I always have a box of tissues there because you never know when someone's going to burst into tears. And I have a little strategy for dealing with it. So the patient will burst into tears. I push my box of tissues over, and then I say to them, if your tears were words, what would they be saying? So that's a very good response to somebody who's crying. And then they'll tell you what's going on inside them. And the key thing in those situations is the patient needs to be seen, heard, and understood. Anyway, I was talking to this woman on the phone, again for a mental health sort of consultation, and I didn't know her and I hadn't met her before. And after about 10 minutes, she burst into tears. And I literally didn't know what to do because I didn't have any tissues because I'm in front of my clinic computer screen and I couldn't see. You realize how much you rely on people's body language. I didn't know if she was lying in a heap on the floor or she was just having, you know, a low level cry sitting in her seat. So, so there are some things that doing things online are much more difficult. So, so our clinic has continued. So it's been much quieter because the acute respiratory infections are going off to the CBACs. We're not doing any swabbing at our clinic at the moment, although Teresa, and I don't know if Teresa's online yet, she's the GP registrar, she's going to join us shortly. She's up at Silverdale, and in some of the bigger clinics, they're actually doing their own COVID testing. Of course, you have to have the volume coming through to be able to allocate a staff person to do that. Otherwise, it's very expensive from a practice point of view. And remember that general practices in New Zealand are all sort of small businesses, so they have to be conscious of you know where they're putting people and doing things. So we're being much quieter, much more on the telephone. A number of things have happened. So one was the influenza thing. So we now do most of the flu shots in the car park. So patients will book in a flu shot and the nurses will go down to the car park, which is much better. People aren't waiting around and they're not being exposed to other people. And of course, most of the people getting flu shots in New Zealand, because it's free if you're over the age of 65, are at risk of COVID mortality if they get it. They're not necessary, though they may be more likely to get it, because what happens as you get past 65 is your immune system starts to drop. And I don't know how many of you have been listening to Michael Baker on Radio New Zealand. Anybody been listening to him on Sunday morning? He's on national radio. Anyone want to put a thumbs up if they've listened to him on Sunday morning? Or on Saturday morning, there's a guy called Chris Smith, who's a virologist from Cambridge in the UK. And so they answer questions. There's the Radio New Zealand Coronavirus podcast, and there's one called CoronaCast from Radio Australia. So there's a couple of things there. So I would encourage you to learn as much about COVID virus as you can, because this could be the only pandemic you're ever involved in your career, or worst case scenario, this is going to happen every year on your watch. So I see Teresa's here, so I might hand over to her.
Hi, everybody. I will.
Do you want to put your camera on, Teresa? Yep.
Yeah, hi. Thanks for inviting me along. Wow, there's quite a lot of people here. Sorry I'm a bit late. So I have missed a bit of what you've said, Bruce.
Okay,
But
I'm
yes.
just describing what we've done at our clinic. So yeah, I didn't catch that you'd turned up. So yeah, so if you just want to talk about what your experience of COVID virus, because of course this is your first pandemic, I would guess.
Definitely, yeah.
Hopefully the last.
Yeah, it's been all very interesting. And diversity and variety is, I guess, what I love about general practice, and this is yet another one of those interesting new things we deal with, although it's affected obviously everyone across the board, but definitely I think GPs are totally at the forefront. So I do work at a clinic where we have been doing swabbing. It's quite a big medical clinic. We have 16,000 enrolled patients. So basically overnight we changed everything, and everything's been basically virtual. Within a week, we have like a separate sort of assessment area outside where basically it was a triage system, and anyone who met any Ministry of Health criteria or was remotely suspicious had to be seen out there, or is still being seen out there, with full PPE. We have done, I don't know how many swabs, but I'm guessing probably something like 2,000. We've had a few positive cases at our clinic, and that was early on. Thankfully, those patients, as most of their patients were mildly affected by coronavirus. I personally didn't see those patients, but I have, I guess, I think my first moment of great awe and terror was when I was swabbing a family of someone with a confirmed case. So they all came in and had sort of mild cold symptoms. Their swabs were all negative, but they had to do their self-isolation, and I realized, wow, I'm really standing here right at the forefront. The information that's come through has been constantly evolving, so we've obviously had our ears pricked basically day by day. New science coming through on possible new symptoms, like the criteria of anosmia, loss of sense of smell was added in. Criteria such as I don't know if you've had a look at those blue fingers and toes. So I guess it's been interesting just to try and keep on top of all the latest things, and all the advice keeps changing as well. Who should we be swabbing? Who shouldn't we? What kind of PPE are we wearing? How to go about tricky things like for example, I had a patient with a breast lump who also had some symptoms, possible respiratory symptoms. So she needed to, of course, be seen out in the car park, in the drive-through area, and that makes it very difficult to do things like a breast examination. Or people who need x-rays, are we allowed to let them into the have their x-rays at the lab, at the radiology place, if they're still waiting for a COVID swab, for things like a chronic cough. So lots of new, I guess sometimes you just hit with those situations that you have to kind of on your feet, or talk to the public health officer for advice. Obviously there's still the false negative rate with the swabs. So it's been really interesting. I guess for me, I'm out in that assessment clinic maybe once a week. So I still do the normal general practice things. I think I heard you saying, Bruce, it's a bit quieter. So it has been quieter for us in the general practice side too. But definitely it's busy again, like today. It's picking up. And that's been a whole nother interesting challenge of moving to using phone consultations and DocsMe as well for videos. Very interesting trying to look at people's funny rashes on the camera and getting them to kind of hold their foot up in front of the camera, and deciding, I guess, who do we actually need to bring into the clinic, who is at risk enough, or who do we really need to send to the lab, and living with uncertainty, which I think GPs are, I guess we always have an element more of uncertainty, I think, than often in the hospital, because we don't always get tests straight away. So really thinking, will this change the management? Do I really need to do that? And the responsibility as well of, I guess, you've just talked to someone on the phone, making sure you really have asked all the red flag questions, and safety netted and things like that. I had a woman I talked to on the phone who said she'd had a history of pelvic pain and bloating over a few months, and she was about 50 years old. So I guess the thing that jumps to me straight away is like ovarian cancer. I hadn't actually clinically seen her, but I just made a decision to arrange a pelvic scan. I thought that was a reasonable thing to do. And she actually she's got an 8 centimetre complex ovarian cyst, and she's going off to have that investigated and taken out. So yeah, like I guess those moments where you realize, wow, you know, I'm glad I arranged that scan, and I thought about that. And it's quite different when you can't see the person in front of you. You don't see how they walk into the room, whether they seem to be in pain, their expressions on their face, how worried they are. So yeah, I found it very interesting and new. Sometimes it's quite nice, the phone consultations, because notoriously difficult as a GP to stick to 15 minutes. When you're on the phone, it's definitely easier to end a consultation than when a person's in front of you. So some things have been good. And I think it is a really interesting time for general practice to reflect on going forward. Yeah, what can we do by video or phone? What should we be doing face to face? And how to go about navigating that. I think the other thing I've been reflecting on is leaving no one behind. One of those, you know, UN sustainability goals, but I think quite relevant in a pandemic situation. I've had quite a lot of, I've had a few patients who I think I've realised the struggles that or lots of struggles, I guess, across the board. But for example, I have a patient who's deaf. And so she can't actually do virtual consultations. I can't even call her to tell her lab results. So I have to message her, and she's been coming in, and she's just recently been diagnosed with celiac disease. But she was sitting there and she was very frustrated because of course she can't lip read through a mask. She struggles with the use of technology. So she's actually got a child, and having to have that child at home to do schooling from home has been a real challenge for her. She was very frustrated about her computer, so we've had to brainstorm some ideas to get someone to help her from the school to kind of facilitate technology at their house. Just made me reflect on those people in our society who are actually easily left behind in this new move towards everything digital, everything technology. Mental health, definitely a big thing. Lots of people calling in very anxious and worried. It's been very nice to see recently with the numbers going down that people are more reassured, but that's definitely been interesting sort of thing, and quite challenging. What else?
On that point, a colleague of mine is in Opotiki. She was saying that a lot of young people have got a smartphone and they've got a smart TV, but you can't easily do a video consultation. It's much more difficult. You realize that actually a desktop computer has some advantages in terms of doing things. And another lady who had to drive, because the phone coverage is so poor down there, she had to drive 25 minutes to sit in her car to make a phone call to the clinic because the phone coverage, she had no phone coverage where she lived. So I think that's a really good point you raised, that it's highlighted that even digital natives can have trouble if they haven't got the gear. The mobile phone and a flat screen television isn't much use if you need a mouse and a keyboard sort of thing. It's not, it's been an interesting, but actually you can be a digital immigrant, and if you've got all the gear, you may be better placed than the digital native who hasn't got such good gear.
Yeah.
I wonder if Annie's got any questions for us. Oh, there was one question about what are some of the examples of safety netting that you managed to use to manage this diagnostic uncertainty? What were some of the things you did?
Guess it really depends on the clinical presentation. In my mind, every type of diagnosis, I have kind of red flag questions in my head. I guess, yeah, like, those questions about, could this be cancer? And if there's any red flag question, then I am really cautious. So I will either bring them in immediately after the lockdown, or really think about how fast I need to get some investigations. But safety netting, I guess that includes making sure that we know their up-to-date contact details. I've had that a few times where I realized, I can't even phone this patient now. Making sure that they're able, I guess, to get follow-up. Are they someone who lives in this area, or have they got another regular GP? So yeah, I don't know if that answers the question.
I had a man who was getting increasingly demented, and his daughter lives in Kaikoui, and he was in Manurewa, and he's not allowed to drive anymore. He's too demented, and he'd been driving, so we had to sort of try and stop him driving, which was a bit difficult. But I had to, so I phoned up to see if she could drive down and take him up to Kaikoui. And there's a government agency, and they said, well, we can't give you permission for that. So I thought, well, this is nuts. This guy's going to do something dangerous if he stays down in Auckland. So I said, look, I'll give you a letter saying it's okay to come down. So I wasn't necessarily breaking the law or breaking any rules, but because there was no way I could get, it seemed reasonable for her to drive to Auckland and drive back up. She's not going to, other than stopping at a petrol station, she's not going to be giving COVID to anybody. Anyway, that went quite well. So we got him out of harm's way, and he's now up in Kaikoui. But there were some odd little events like that that you couldn't anticipate, really. I had to sort of be creative, I guess, and it just seemed to me, well, the safest way to get him from Manurewa to Kaikoui is to have his daughter drive him up in her car, and that worked out. So I wrote a letter, and she wasn't stopped, as far as I know, by the police. So that was during the full lockdown. So yeah, I don't know if you had any cases where you had to sort of ad-lib a little bit like that. It's interesting, that thing about the ultrasound, isn't it? I mean, also because we know that pelvic exams aren't particularly helpful in those situations. Actually doing it, if you've got doubt, then you want to do an ultrasound, at least in the first instance. And actually in the UK, they're actually encouraging CT scan much earlier on, because as you know, ovarian cancer is such a difficult diagnosis.
That's right, yeah.
It terrifies all of us. The 50-year-old woman with lower abdominal pain, we all live in fear of that. So that was a good move, I think. So well done. Yeah.
I think also people who are sort of repeat presenters, to just have an antenna out for, like, someone who might have called in a few times. I have a patient who has just registered under me, who was initially consulted by someone about like some headache and just basically pain around the ear, very non-specific kind of symptom, nothing else too alarming. This is a patient that's in their 50s, possibly a little bit of mood stuff going on, maybe a bit of a low mood. So that kind of, there wasn't any specific red flags, I think, that were picked up during that virtual consultation, but that patient had presented again with basically just for a clinical review a few weeks later, ongoing symptoms, nothing really major to be found. A lot of questions, was it, pain coming from the neck? Is it anything else? They had a raft of bloods done that were normal. And then they've sort of presented again. And this time round, basically this patient had a markedly altered personality very weird, sudden deterioration over a few weeks of basically loss of memory. A mini mental status exam had quite a low. I think their mocha was 17 out of 30. I don't know if that means anything to you guys, but very, very. This went from a high functioning individual to someone who like basically was just vacantly staring into space. Weird things going on. So this patient's been admitted acutely into hospitals currently, being tested. I've spied on an MRI result, which has raised some questions about possible diagnoses, such as I think they're questioning something like prion disease, something I've never come across. So I guess that showed me like just a really unusual, weird presentation that sort of general practices can have really weird and interesting things happen.
Well, the doctors in training, they get a couple of lectures from me and David Minkeys on medically unexplained symptoms, and it's a real, I mean, you're taught to make a diagnosis, but actually even in tertiary hospitals, half the patients have medically unexplained symptoms. So it's really a part of medicine, isn't it? And it's interesting what you say about that, because in our clinic, if a patient comes back for a third visit with the same problem, it's mandatory to have a second opinion from another doctor in that clinic or one of the nurse practitioners. So you get some, because that's when you
That's a good way, yeah.
Well, that's when you look at the medical protection disasters and people just keep doing the same thing. You know, if the patient's not getting better, you've either got the wrong diagnosis or the wrong treatment, and you need to share the responsibility. And there's nothing more joyful in medicine than sharing the responsibility. And somebody comes in with some good ideas usually, or you both decide maybe you need to see them to hospital, either acutely or, you know, as a referral. But, you know, some of these cases you see where people keep doing the same stuff, it's just crazy. I found I spent more time on the phone, actually. Well, it is easier to terminate. I was always worried that I hadn't got to all the red flags, you know, that people, that I just wanted to make sure people were okay, and they, I felt I had to give more value for money and spend more time talking with people. So I actually found it was slightly more time consuming with people on the phone than face to face. I don't know if you ever had any experiences like that.
Yeah, I guess also because it's been quieter, I've been allowing myself to have more time with people when I can. And that's actually been really rewarding, because it just means that you feel like you're being more thorough and you really can answer all their questions. Yeah.
Yes, I came across a couple of things interesting. I found some families, notably my friends and their families, have actually become closer during the lockdown. But I also talked to a lot of people where the families were sort of falling out and fighting, and young solo mothers with male children aged about 3 seem to be a very at-risk group in terms of stress, because the kids couldn't get out and play. They couldn't get anyone to come in and help them. I don't know if you came across anyone in that sort of category, but I
definitely, yeah. I've had quite a few mums coming in losing their hair, like alopecia, which can be like iron deficiency or thyroid problems, and you think about all the medical reasons, or skin disorders of the scalp, but often just stress. They've been at home struggling to juggle working from home and the kids. Yeah, seen lots of financial stress as well, people losing their jobs, and yeah, you can see the impact of the pandemic has been very, very great. I think the other thing I've been a bit worried about is people missing out on their specialist appointments. Had lots of letters back from specialists. I don't know if you've found that, Bruce, that people are sort of, yeah, waiting times are longer.
I think the government's putting on a little bolus of funding, and probably a lot of that stuff's going to be referred out into the private sector, which may help the public sector catch up. I mean, there's quite, I don't know whether the doctors in training know that, but a lot of stuff is contracted out into the private sector where there often is more capacity. Sometimes there's surplus capacity. So if the waiting lists get too long, a lot of our colonoscopies are done in the private clinics. So the DHBs get a good deal in the private clinics and get the volume going through. But yeah, no, you have the old patient you're quite worried about, and you can't get them seen. So it can be a little bit frustrating.
Mm.
So we've got any more questions from Kelly?
Yeah, we do have just a couple more questions. So one being, as well as the Goodfellow GEMS, the breathlessness assessment, are there any other additional resources that students should be aware of prior to going onto GP placement?
There is quite a good thing from, and I could flick it out to you, from Red Whale. So Red Whale is a UK update. I could email to Kelly, who can send it out to your members. So Red Whale is a GP update group in the UK, and we run their annual program here in Auckland, and it's coming up in September this year, and they wrote quite a nice thing about how to deal with phone calls. One of the things that often isn't mentioned, actually, and it's always been something I've been cautious about with patients, if you can't speak the same language as the patient, you have to be very, very careful, because many years ago I was called to see a Samoan woman. She was in her 20s and she had vomiting, and I didn't get much of a history on the phone, and I was slightly sort of frustrated to have to go and do a house call. And when I got there, I found she was quite pregnant and had very high blood pressure and was quite ill. But I, of course, got none of that on the phone because I didn't. So you need to be doubly cautious if you can't speak the same first language as another as your patient. So that's something to think about. And one thing you were saying, Teresa, I was just thinking about, I can remember doing an abdominal had a Samoan lady with a acute abdomen, and her English, she wasn't particularly fluent in English. And I realized, palpating her abdomen, how much I relied on the verbal communication and the body language to assess how severe it was. And I realized it was incredibly difficult to do an abdominal, you think an abdominal examination is a physical thing, but actually it's a communication exercise as much as a physical assessment. You're trying to get the subjective feeling. You press here and then you press a bit harder, and you're trying to judge how much this is hurting the patient. And I remember feeling like I'd got nowhere with this lady. Any comments on that?
Yeah, definitely. I think, I guess one thing I found quite hard is doing examinations in the car.
Yes, well, doing
like abdominal examinations and things.
Because you'd have the privacy issue, and
yeah,
it would be, and I guess you can't exactly get a chaperone to come into the car with you.
So like, even if the patient has a fever, that's like a criteria to not come into the clinic. And a fever, of course, could be anything. So yes.
Well, we got used to that during the measles thing. We had a number of cases, and that's quite interesting. I mean, you said you've had a couple of COVID cases at your clinic. Well, in our clinic, we had about 3 measles cases. And when you get something like that happen, and I haven't seen measles for years, when you have 3 cases at your clinic, something big is happening out there. There's something very big happening out there. And we stopped people coming in. Anybody with a rash had to phone first. And fortunately, in measles, people with acute measles are pretty sick. They're coughing and they don't look very well. And so you could probably judge that fairly quickly by the phone. But the problem is, somebody comes into your waiting room with measles, you have to notify everybody 2 hours before and 2 hours afterwards. So the workload for the admin staff is huge. You're trying to track down all these people and who was there and who was with them. There's all that contact tracing stuff that I guess we're much more familiar with now through COVID. In fact, I know one of the things when Ashley took over as Director General, the public health function of the ministry was pretty feeble, and he wanted to beef it up. And I imagine he's going to be able to beef it up forever now. They're probably going to need to have a group of people they can train very quickly in future. When you can't have 300 people on the payroll waiting for the next pandemic, but they probably have to have a system in place whereby they can train people, because I think they have 300 or 400 people now doing the phone contact tracing, because they've managed to get 80% within 48 hours. That's their target. That's the international target. Of course, the real problem with contact tracing is trying to contact people. I mean, I don't know what trouble you have, Teresa, but you know, I phone people up, they don't answer their phone, they haven't got money on their phone, lost the phone, if they've got a new phone number. There's all that. You said quite nicely that you want to, there's one of the safety nettings is making sure you've got the phone number and email address. And it's a real problem these days. Most people don't have landlines anymore. Landlines were much more reliable, I think, for getting people. You could at least get hold of the household. People may have a personal phone, but it's not necessarily on, it's not funded, and it may not be with them. So it's become a modern nightmare contacting patients. I don't know how they're doing it. Any other questions there, Annie?
It's sort of like a follow-up from the question before, but it's more if there are any extra skills that would be useful to know in this climate, in terms of going out to GP placement for the clinical students.
Well, our students, the 4th and 5th year students were taken out of their placement this year, so they had to learn at home, and we provided a whole lot of really cool resources. In fact, I will email out a whole lot of tutorials we've run, particularly for those of you in 4th and 5th year, on the Red Rash Made Easy, common infections. We ran them for the 4th, 5th and 6th year students. So the department, if you go to Canvas, you'll find a whole lot of really wonderful resources there at the moment. That's been one of the benefits. My department just worked like 24/7 for about 2 to 3 weeks developing online resources. So we've got used to using Zoom, and we ran tutorials for the students. So I guess learning as much as you can about COVID would be pretty good, because there's lots of stuff out there. Understanding what the problem is going to be about developing the vaccine. There's no vaccine for coronavirus yet. I think there was one made for MERS or Ebola, which are similar sort of viruses. Understanding a bit of that sort of stuff, I think, would be pretty interesting. There's almost too much information at the moment. It's just sort of flying around. The journals are pumping out stuff. But as I said, the podcast, Radio Australia podcast, Radio New Zealand podcast, listen to Michael Baker, 20 to 10 on national radio on Sunday morning. I love listening to Michael. I was saying before you came on, both Michael Baker and Ashley Bloomfield are Auckland University graduates. So I'm quite keen to get them on a webinar at some point and ask them what in their training made them go into public health. And the funny thing is, neither of them are show ponies, and yet they've got this enormous public image. I don't think you saw my T-shirt, did you, Teresa?
No.
My Ashley Bloomfield T-shirt.
Oh, awesome.
It's actually, we were going to use it as a prize for Public Health Week, but I rather like it. I'm not sure I want to give it up. I haven't been brave enough to wear it in public, but I've got a photograph of it, which I'm going to send Ashley. So
I hope you get an autograph from him on there.
I'm sure I can. I'm reluctant to bother him at the moment. I send a little note saying, you know, powerful stuff.
Yeah.
He must have been working hard.
Yeah.
Having to communicate with Australia and all the people around the world. I mean, it seems to be what's going on. There's 180 experiments going on around the world in different countries. And we're not going to know what the best one, you know, was Australia better than us, or, you know, like if our tourist industry takes off, we may, you know, if we don't have COVID here, we may end up having a huge tourist industry here. I can imagine rich Americans being willing to come for a couple of weeks quarantine, and then they can travel wherever they want. Conversely, I wouldn't go to the United States of America at the moment until the vaccine's available. So if you could fly to a country and there be no COVID, well, then you can wander around quite happily. You know, I think there's some interesting things. You know, it'd be nice if we're one of the first countries to be completely free. It looks like we're heading that way.
I think one of the clinical skills is just communication, and I think people really look towards doctors as an example. I guess we've had some, people look to see, you know, how are we behaving ourselves? You know, is she wearing a mask? What is she doing? And I think just setting an example in the way we go about, and whether that be, I guess, just having that tact of seeing, oh, this person is extremely anxious or unreasonably anxious, perhaps my role is actually to provide some positive education in terms of, you know, is that anxiety a bit too much? Can I perhaps reassure them a little bit with what's happening now? Equally, people who are extremely blasé and like not, you know, maybe not following the rules, you know, perhaps educating more on that. So like just learning to see where a person's at and how you can kind of shape their view on things, because actually if it's not GPs who are on the forefront, like basically it's the media, and then we know how media can be very unreliable as well. So I actually think there's a big responsibility.
Well, the media's looking for the headlines, aren't they? And I think, I had an interesting case of a man. He flew back from Australia to New Zealand, and he got in just before the midnight closing. And it had some difficulty. He made a complaint to our clinic about something. I can't remember what it was, but he said, well, I didn't have to go into self-isolation because I got in before midnight. And I sort of said, I think you actually should. You know, just because you managed to get in under the wire, you know, for your sake and the community's sake. And he was a bit sort of taken aback by that, but I think that's a good point you make, that we have to be good examples. But also looking after yourself, I think, is, you know, getting plenty of sleep. Actually, there is one thing, I haven't put this out as a gem because I didn't want to destroy New Zealand's supply of vitamin D, but actually there is some evidence that vitamin D, regular taking of it is protective against acute respiratory illnesses. Now, we don't know whether that's true for COVID or not, but there was a Cochrane review that I hadn't picked up, that somebody pointed out to me. It's much more likely to be beneficial if you've got low vitamin D. So for some reason you won't have, you know, if you don't go out into the sun very much, you may have low vitamin D in New Zealand, or you don't drink milk or dairy products and things. So there are some people, but getting lots of sleep, don't drink too much alcohol, keep physically fit, learn how not to worry about things, learn how to hold things lightly. I had an article in the Medical Student Journal, those of you who got it, called Learning to Run Your Life and Mind Effectively When There's No Life Instruction Manual. And it's got half a dozen things to do to learn to deal with your stress. And one of the key ones, actually, and I've talked to some of you about it before, is learning your dashboard warning light. So when you're in your car and you run out of petrol, or the petrol light comes on, you go and get petrol. Well, you need to do the same with your life. The moment you realize you're getting a bit stressed, then you have to keep doing the good things in your life and stop doing the bad things in your life. So that's a good little bit of advice to learn. So understand, I ask my patients if they know what their dashboard warning light is. And I write it in the little history part of MedTech, Teresa, so that I can get back and see it. And so usually what people do when they get distressed is they stop going to the gym, they stop seeing their friends, they increase their food intake, and they'll increase their alcohol intake and perhaps substance intake. And of course, you have to reverse all those things, you know, more of the good things, less of the bad things. But it's a natural human response to distress. And as doctors in training, you're going to be under lots of stress. You've got exam stress, workload stress and all that sort of stuff. And when you're a junior doctor, you're going to be in hospital under a lot of time, day, night. You'll be working nights. Maybe you'd like to say a little bit about working nights, Teresa, for the doctors in training. What's that like?
I've done many, many night shifts.
What's it like?
So I guess there's a part of me that finds it very exciting because it's very acute stuff. It's acute medicine. It's not like, I guess it's not as much like paperwork and stuff like that. It definitely puts you out of your comfort zone. There's less support, so you do have to make more independent decisions, and I guess same as general practice, really safety net. And if in doubt, admit the patient, don't send them home, or call your boss, and really know like how to do the 777. If you really someone's crashing, I guess. And where I've been working obstetrics, it's been very, night shifts can be from very quiet to absolute havoc emergencies left, right and center, and just being prepared to face emergencies, knowing your algorithms in your head, and if in doubt, calling for help. I think there's that sort of 3 to 5 a.m. low. You start getting cold, tired, hungry, and just, I guess, making sure that you always have snacks around, making sure you have been rested, which can be really hard. Transitioning in and out of nights can be really tricky. I definitely know I'm guilty of pushing myself too far, but just actually having, I guess, recognizing your own dashboard warning signs of when you need to get help, sleep, whatever it is.
The best war stories happen in the middle of the night, don't they?
Yeah.
It's also like in general practice, your most difficult patients, the ones who complain much and you find very frustrating, often provide the best war stories. They're the most memorable ones in a funny sort of way, because they cause you more grief in that way. Well, it's sort of interesting. You don't need to. I worked in a little hospital in Canada, and one night we had a man who'd shot his face off with a gun, and then the local sort of community alcoholic came in vomiting blood. So we had 2 people who were in massive blood deficit, and they completely tied up every nurse and doctor in that hospital. There were 4 doctors and about 12 nurses, and it only takes a couple of emergencies to tie up an awful lot of health professionals. I can remember in Auckland Hospital having a group of motorcycle guys who were in a big crash, and there were about 3 or 4 of them sort of bleeding to death, and literally there were just 50 or 60 people completely tied up with just dealing with those sort of situations. So I just have an image of you in that obstetric havoc. That I think it's really very demanding on acute resources when you have emergencies. A lot of people are involved.
To prioritize, and delegate.
If you can, well, you say often there's not the extra staff at night time, is there? Often, you literally holding the baby or not holding the baby, and that's
something. What things can wait and not. But even in general practice, you might be surprised to hear there are some nighttime calls. So I didn't think I'd be doing any nighttime work, but I had a patient, this is before the pandemic, who came to see me, actually had fallen off his motorbike and broke his, broke his hand basically. So I spent ages taking the history about his hand, and we got an x-ray, and I was like, we got it casted and did it all. So he had been with me for about half an hour, kind of gone over to his x-ray and back. And then just as I was checking the cast, he was like, oh yeah, and I did have a bit of chest pain when he'd fallen off his motorbike. And he's a Maori patient who's got quite a lot of risk factors for having heart disease. So I was like, definitely can't ignore that. I need to follow that up. kind of wishing he'd told me a bit sooner, to be honest, now that I've been with him for half an hour and got more patients are waiting. So I got the nurse to do an ECG, which was normal, and I said I basically got a troponin and like did a blood sample because it had happened kind of 6 hours prior or more. So I was like, well, if the troponin comes back positive, he's had a heart attack. If it's negative, it's not. So I said to him, you've got to answer your phone. I will be calling you later. The troponin didn't come back till quite late that evening. And I got a call from the lab and his troponin was like more than 2,000. And then I was thinking, oh my goodness, like, what am I going to do now? Like, I'm going to have to track this guy down, and it's like dark and night. And basically I couldn't get hold of the patient. And I was like, oh no, like, what am I going to do now? He's had a heart attack. He's out and about. So I got hold of the practice nurse, and she actually lived on the same road as this patient, and she watched around to his house. And he was just at home hanging out and feeling fine, and he didn't actually want to go to hospital. And so she said, no, you actually must go to hospital. You've had a heart attack. And then he did agree to go. And yeah, he came back and saw me about a week later. And he had made a deal to stop smoking, so that was quite cool. But yeah, so sometimes we get random night calls.
It's an attempt to stop smoking after he's had the heart attack, isn't it? I mean, what we aim to do is to get people to stop smoking. The aim is to get people stopping smoking by the time they're 30, because then they'll live a normal length of life. But for every year you keep smoking, in Canada they used to have cigarettes, which as you smoke them, it shows how many minutes of your life you're losing. Because of course, the more cigarettes you smoke, the more damage you're doing to your body, basically. And sadly for you doctors in training, you're still going to see the tail of smoking. There's still enough smokers around who'll have smoking related damage. I was just talking with my hairdresser today about cannabis reform, and I was saying, well, I'm not going to be too bothered if people were able to take the oral form of cannabis, but I'd be really worried if people start smoking it, because the last thing we want is another epidemic of lung damage. And the New Zealand evidence on lung cancer from cannabis is fairly convincing. The overseas stuff isn't. The New Zealand case control study is one of the best done. It's done by Richard Beasley in Wellington. So I mean, if you're inhaling organic compounds into your lungs, you're going to do some damage to them. And it's not a moral thing, it's really a health thing, basically. I don't have a moral objection to cannabis, but the inhaled form, I think, if the legislation comes in, then you as doctors in training will be seeing a lot of lung damage later in your life. I've spent my life, I was the chairman of ASH for 5 years, and spent most of my life trying to get people quitting smoking. Sorry, Annie, you're back on screen. Microphone, you're muted.
Oh yeah, here. Yeah, so thank you for all of that. We do have one last question, but before I go on to ask that, I was just wondering if you guys had like specific cases you wanted to present, just because we are going a little bit over time, so I'm just being aware of that. So
well, I've got some cases, but if you want to finish, that's fine, up to you.
No, we
Depends
can.
how much the audience wants to if they want war stories from Teresa and Bruce, then we can give them a few.
Yeah, we can definitely do that, because it is recorded, so people can come back and watch it if that's what they like to do. So would you prefer that I ask the last question first, or do you want to?
Up to you. You're the boss, Annie. So
all right. Great. Just one last question. Do any of you think that this pandemic will change our way of running GP clinics in the long run, and whether this alternative way of consultation has made any positive impact on removing the barrier of access to healthcare for those who could not easily access healthcare before? A bit of a long one.
Do you want to have a go at that, Teresa?
I think it will definitely change general practice, yes. Already has, I guess, the move towards virtual consultations. I think that whilst we will hopefully still be seeing people face to face, I do think that that move is there will be some lasting changes there. It's certainly convenient for some people. If they're busy mums at home, it's way easier for them to phone in on something. I think the way that we run the clinic, like there was evidence that came out of Italy about the spread of viruses in waiting rooms. I think that's definitely an area to watch. What will we be doing? At the moment, we're social distancing in the waiting rooms, but I think there's a great public awareness around that, and how do we keep everyone safe. The idea of, I guess at the moment, the idea has been to have green and red zones in the clinic, to have not be mixing well and unwell people. Is that something that will be continuing? Those are probably my initial thoughts.
I think people would be willing to do like a young mum at home, much prefer to talk on the phone than have to come in with kids and babysitters, and the kids are running riot and the doctor's running half an hour late. I mean, it's much more convenient. I've had a couple of patients who actually wanted me to phone them at work, and they only had a specific slot, and I didn't call them at that time, and they were pretty annoyed. So that was one little pressure I felt. This woman wanted to be called at 10:30 because she'd left her desk to go to the tea room to take the phone call. So there's going to be a few teething problems like that. But I was just saying, probably before you came on, Teresa, we may actually keep acutely unwell people in the cars and either go out and see them in the cars, or call them in, text them in, and come straight into a particular room so they're not in the waiting room. I mean, we've been a bit cavalier, I think, with mixing sick people with well people, and I guess in general it hasn't mattered too much, but the COVID virus has shown you don't want a whole lot of vulnerable older people around a whole lot of young children with respiratory illnesses, which we do. I mean, it's nice for them to be mixing together socially, but medically it's actually not a good idea.
Yeah, I think also, I wonder if GPs will be managing more things if there is a backlog on the system. I guess there is also the potential for us to take more on hand and maybe upskill, or just, I guess, the new electronic communication with specialists where you just get advice and you can perhaps do more things. I guess there's lots of scope in general practice to subspecialize. At my clinic, we've got someone who's doing allergies, we've got someone who's doing sleep medicine, I guess for me, women's health stuff. Whether there's that sort of a shift happening as well, that will be interesting to follow.
Yes, I'm hoping the hospitals get more efficient. I just had a patient, one of the problems, if you have a hearing test and there's an asymmetry between the sides, you need to get an MRI to look for a seventh nerve tumor called an acoustic neuroma. And but you have to make the patient go to see an ENT surgeon to order the MRI. And it just seems to me we just need to have a system whereby if you've got the hearing test, you should be able to get the MRI. It's a waste of, and I referred this particular patient, and because of the virtual clinic, they didn't see him, they just ordered the MRI, which they could have avoided the intervening step and had me, so long as you've got an official hearing test and it shows asymmetry, they're going to do an MRI scan. So there are a few little things like that I hope will change. The communication with the hospital is getting much better, I have to say. I don't know what you find with this electronic referral thing, but you can often just ask for advice about things, which was very hard before. A lot of the hospital doctors carry mobile phones now, and you can actually talk to them, which is a great relief. Sometimes you just want, 2 minutes advice, and that's all you need, rather than sending somebody in. So I'm not averse to phoning up a hospital specialist and saying, I just want to talk about this case. I don't think they need to come in, but it's that thing of sharing the responsibility, so that you haven't got the monkey on your back. I talk about the monkey on your back, and it's a lot of medicine's about dealing with the problem and getting the monkey off your back. So it's not something you're carrying, that you've actually done something about it and got the patient moving in the direction they should be.
Thank you. Thank you for answering that. Yeah. So I suppose we can wrap it up with your cases, if you like.
Okay. I've got a case I could talk about if you like. So I don't know what level students you're at, but I had a lady who was 49 come to see me with a cough that had been going about 5 or 6 weeks. And her mother actually phoned up and said, I'm concerned about her. It's unusual for a 49-year-old to have a mother phone up, but it does happen. And this woman, when she came in, she didn't have any sort of symptoms or signs that were concerning, except the fact she'd been a smoker from 15 to 30. And that spooked me a little bit. That's quite a lot of smoking. She'd been quite a heavy smoker. So although she was 49, she'd had years without smoking, and technically she should go back to normal. That spooked me a little bit. And so I gave her a short, from the diagnostic test point of view, her pre-test probability of something going on causing the cough has gone up a little bit. She's not your typical patient coming in with a post-viral cough, although that was my starting point. She was just a little bit more risky. I gave her a short course of prednisone in case, although she had no wheezing in her chest, I gave her a short course of prednisone, and that's a steroid cortisone which settles down asthma. So sometimes people will have a little low-level asthma attack, and that really didn't make any difference. So I gave her an antibiotic just in case. And after a week, it hadn't got any better. And I got a chest x-ray. And the chest x-ray said she had pneumonia. So this is an important point. So I got the lady back in and I checked her out. I listened to her chest. She had no signs in her chest. Her temperature was normal and her pulse was normal. And I said to myself, that chest x-ray is wrong. She does not have pneumonia. She's got something else. And fortunately, she had private medical insurance, so we were able to get a CT scan within a week. And she turned out to have a stage 4 lung cancer, which unfortunately was terminal. But I just give that case as an example of pre-test probability. So her pre-test probability kept going up. She wasn't responding as I'd expected. So I started to suspect something more serious going on. And one of the things with people who've been smokers, if they've got a weird presentation, you need to hit the panic button and get a CT or chest x-ray in the first instance, but have a low threshold for getting a CT scan. Because lung cancer is curable if you can get it early. The trouble with most lung cancers is they present very late, and people have got stage 4 disease, which sadly was the case in this lady. But I mean, it may seem very bold, me saying this lady does not have pneumonia. She does not have pneumonia as I understand it. Whatever that x-ray is showing in her chest is not pneumonia. And of course, it turned out to be a cancer rather than pneumonia. So it's learning to be suspicious of diagnostic tests. Don't believe them if the clinical picture is not matching that. And one of my colleagues thought, I was amazed at how quickly I went to CT scan. But if you just think of the logic, I'm spooked by the 15 years of smoking, and nothing else was adding up. She just wasn't getting better. So clearly I didn't have the right diagnosis. I had to dig deeper. And the ultimate for chest things is a CT scan. And I appreciate for those of you in the early years, that may seem like a series of giant leaps, and you wouldn't normally do that with most people who come in with 3 or 4 weeks of a cough, but she'd be going just a little bit longer, and my suspicions paid off. So Teresa, have you got someone you'd like to talk about? Your man with a heart attack is pretty amazing. Was some of that muscle damage? Had he damaged? Is the troponin cardiac specific, or is some of that being muscle damage?
I did think about that, but he had quite a lot of risk because he was a smoker. He was Maori. He was in the right age group with a significant family history and hypertension. And he did go on and have an angiogram that did show some vessel damage. I guess erring on the side of assuming the worst case scenario is the best way to go as well.
Well, in terms of pre-test probabilities, you could argue that his pre-test probability was sufficiently high to warrant a troponin. What age was he? What age?
50s.
Yeah. So the Maori man, that's equivalent of a Pākehā at 60. So you're right in coronary artery disease territory there, aren't you? Particularly with smokers.
Yeah.
Right. Great. Is there anything else you guys would like to add to that?
No, we've got some other cases, but I think your audience may be getting a bit hungry by this point.
Yeah, I'll just give everyone last chance to send me through very quick questions. But otherwise, thank you very much, Bruce and Teresa, for taking the time to inform us of the current situation, and we're very grateful for what you're doing for the country.
Well, very impressed that you have a GP special interest group. So I'm very keen to support you in any way I can. So thank you for the invite, and thank you, Teresa, for helping with the education here.
Yeah, thank you. So hopefully the link to this recording will be up on our Facebook page. So please go give us a like and a follow and share this with your peers who haven't been able to make it tonight. All right, so I think we'll finish it off there. I hope you guys all have a good rest of your evening. Have a good dinner and watch this space for more events to come.
Okay.
Thank you very much.
Thanks, Annie. All the best with all your placements.
Yep.
Thank you. Thank you.
Thank you, guys. Thanks, Teresa.
Bye. Thanks.
Bye.